Distinguished speakers, mentors, panelists, ACE and IFS colleagues, dear friends, it's truly a privilege to welcome you all to this very special segment of ACE IFS webinar. For the last 2 years, through this webinar series, we have tried to bring together different aspects that can strengthen embryology practice in our country. And we have discussed the techniques, scientific advancement, inspiring journey, practical concern, gray areas, and debatable issues as well. All with one purpose to help our embryology fraternity learn better, perform better, and contribute more meaningfully to the fertility care. Today, we are going to focus on one very important but less formally taught area, that is the human side of ART. We all know assisted reproductive technique is built on science, research, technology, precision, and skill. But above all, it is built on hope. Behind every oocyte, every sperm, every embryo, every treatment cycle, there is a couple carrying dreams, expectations, anxiety, and emotions. And in such difficult moments, failed fertilization, poor embryo development, no blastocyst formation, difficult PGT result, or repeated IVF failure can be a difficult aspect to communicate to the patient. And nowadays, since patients are aware, they wanted to know about the embryo development from the people who are taking care of those embryos. Yet, communication and counseling skills have not always been a formal part of embryologist training, and that's why today webinar is important. Through this session, ACE and IFS has taken one more step towards patient-centric fertility care, where science remains strong and communication becomes more empathetic, clear, and responsible. So on behalf of ACE, Academy of Clinical Embryologists, and IFS, I warmly welcome all our distinguished speakers, panelists, colleagues, and participants to today's webinar, The Human Side of ART, Communication, Counseling, and Compassionate Care. And I have the privilege to guiding you through this program. Thank you for joining us, being part of this meaningful initiative. We are honored to have with us the distinguished leaders of our societies whose vision continue to shape the future of fertility care in India. And it's my privilege to invite Dr. Neena Malhotra, ma'am, who is president of Indian Fertility Society. Ma'am is professor and head of the Department of Obs Gynae, AIMS, New Delhi, and the director of WHO Collaborative Center for Research in Human Reproduction and Cervical Cancer Prevention. She is also an expert member of the National ART and Surrogacy Board, Government of India, and has made outstanding contribution to the reproductive medicine, research, education, and policy. Ma'am, your dedication to excellence in education, ethics, and compassionate fertility care continue to inspire us all. May I request you to kindly address the audience and share your thoughts on this important initiative. Over to you, ma'am.
Good evening, everybody, dear seniors, colleagues, senior members from ACE, IFS. I think I feel really, truly honored and really delighted to be here. I feel a little embarrassed to be used as a, guest of honor, guest chief guest. I think I'm part of you, all of you as a community who work very hard to make realized dreams of couples who are wanting or are keen to have a baby. And I know in this kind of a journey, when the couple is going through the turmoils, the emotional, financial, and a lot of pressure, I think we talk as clinicians a lot of science. As clinicians talk about what is the best way to stimulate, get them the best eggs, to a lab who'll say, what are my best protocols to create the embryos? But then behind that lies the psyche of a couple who do understand this partly, and who are with us. But how much do we understand the emotions and the turmoil that lies behind the surface? And I think I would like to congratulate both IFS members who've taken this initiative, the IFS Counselling SIG, who've really taken this initiative to come in sync. Because at the end of the day, we should look at the couple holistically rather than talk about science and the emotion separate. I would simply say if the embryologist or the embryology is the soul of an IVF, I think the conscience or the voice of this whole program is counseling. And I think this is the best way that we could sort of come in sync, come and bridge the gaps that we have in understanding how to sort of counsel the couple, how to really talk. And I think there was something before we started, how much should an embryologist be a counselor? And I think how much should it be the counselor knowing embryology? I think there's nothing that it is my area or we can working in silos. We are all in sync. And I think we should understand that each one of us is a counselor in every way, and be a clinician or be an embryologist. So I really look forward to this exciting kind of a webinar that is first of its kind. Congratulations to Dr. Rajvi, Professor Arvinda, Dr. Poonam, Gaurav, and all of you all who are from ACE. And I think this will be a very great initiative, and we'll have many more of such webinars, which will be insightful and meaningful for all our viewers. So thank you very much for this invite, and congratulations on this endeavor. Manisha, is that all, or you want me to speak more? You're muted. I think that's all from my side. And I look forward to a very exciting deliberations in this 1 hour of yours that you take forward.
Thank you very much, ma'am.
Thank you so much, ma'am, for your inspiring words and for emphasizing the importance of compassionate communication in fertility care. And we are glad to know it has already been happened in US, and we are trying to follow the same train. And it is now my honor to invite Dr. Sujata Ramakrishnan, President of our Academy of Clinical Embryologists. May I have her CV, please? We all know her. She is an American Board of Bioanalysts Certified Embryologist, Laboratory Director, and one of the India's senior clinical embryology leader with more than 25 years of experience. Her journey across leading IVF centers in India and abroad reflects technical excellence, mentoring, and deep commitment to the growth of embryology. So, over to you, ma'am. Dr. Sujata, ma'am?
Yeah, I am there. Thank you very much, Manisha. Good evening, everybody. Thank you, Dr. Neena, ma'am, for that wonderful, that lovely opening remarks. And I also thank you for this initiative. So today we are going to discuss a very important topic in IVF, that is counseling. See, a couple of decades back, a senior consultant I heard her mentioning that counseling, IVF is all about counseling. If that is done properly, then I think the journey of IVF need not be as daunting or as stressful as it normally is, not just for the patients, but also for the service providers. So now we understand or appreciate the importance of counseling, but we have to know that like counseling itself is a very broad and an imprecise term. The reason being, it involves so many things. We provide information, we offer support, then we manage expectations, we address concerns, and we also help patients navigate the uncertainties of that IVF journey. So different aspects of counseling are delivered by different professionals, each bringing their own expertise and experience. So today, our focus is specifically on the embryologist's role in counseling. Now, counseling actually, there are certain nuances which actually can make the counseling challenging and important. And one is kind of sticking to the domain. For example, if an embryologist is talking to the patient regarding their blastocyst or their fertilization rate, and if the patient asks them something which is not relevant to the lab, how do they handle it? How do they redirect the questions without being dismissive or without being, offensive? I feel that actually requires an exemplary communication skill and presence of mind. So today, this lecture will focus on all the important points which can actually make a embryologist talk to the patient with confidence and compassion. So before I hand over the session, I would also like to remind the attendees about the ACE accreditation exam, the first of its kind in India. There's an accreditation exam for embryologists, like an ESHRE exam. And this time we are having it at the conference venue during ACE Agra on the 7th of August at 4 p.m. So people who are interested, please visit the ACE website or talk to any of the ACE representatives. And I encourage many of the embryologists to take this examination. I'm sure it definitely would help you to further your career. So with that, thank you very much. And I'm really looking forward for an engaging and an insightful lecture. Thank you.
Thank you so much, ma'am, for your insightful comments and your emphasis on combining scientific excellence with compassionate communication has beautifully set the tone for today's webinar. We now move towards to our first scientific session, and it is my pleasure to invite Dr. Arvinder Singh to speak on his action to counseling in ART. May I have her slide, please? Yeah. Professor Singh is a psychologist, leadership facilitator, and organizational consultant over 30 years of experience working in areas of emotional resilience, psychological safety, leadership development, and team effectiveness. We look forward to her insights on how counseling principles can be meaningfully integrated into ART journey. So, ma'am, the stage is yours. Looking forward to your talk.
Muted.
Okay, yep. Thank you very much for that very kind introduction. And thank you, Dr. Nina, for this really pioneering initiative, much needed. Maybe a lot of people sensed it, but you're the one who just took it forward and really lit the torch. And thank you to all the others who are supporting this torch. And I'm very privileged and honored to be a part of this baton. Suddenly, I'm learning about embryology. Suddenly, I'm hearing words like blastocyst. And I'm just so excited that psychology and embryology are going to have some kind of a jugalbandi today. What I'm going to really talk about today is really the human side of embryology. It's like, when a embryologist or a fertility specialist looks at an embryo, what do they really see? As you all said, a blastocyst, a development potential. But what does the patient see, when you're really talking about an embryo? The patient sees their future child. The patient sees hope. The patient has fears. The patient has years and years of struggle. And for many, this may be their last chance. So, as embryologists, we all really work at the intersection of science and human emotion. We all understand that. So it's not like I'm going to tell you something that is just going to be so out of the world that you don't know. You all have been practicing, and my personal experience with some of you has been really, really full of empathy and compassion. I do know some of my very close doctor friends who sometimes carry the disappointments at home. I remember the other day, we were at a dinner, and a friend of mine who's a pediatrician, and she wasn't quite herself. And I just kept asking her. I said, it's what's happened. You're not looking yourself. It's your birthday. We're all here. Are you okay? And she just turned around and she said, I don't feel like celebrating because I just lost a baby in my NICU today. So sometimes we carry that pain as well, even though we may be very professional. We may be thinking that, we don't have anything to do with the outcome. But I think knowing and remembering that every patient sees their doctor as a messenger of hope. And hope you must deliver. Hope you must deliver, but a realistic hope. Not false hope like sab theek ho jayega, Bhagwan sab theek karenge. I don't know what that hope really translates into, but a more informed hope, a more realistic hope, a more compassionate hope. But we must offer hope. No hope is not an option with us. Not in your profession, not in my profession. Hope is the crux of our work, And it's like we can't predict the outcome. But if there are any signs, we can really continue to support the patient. So if a patient is asking us, So that would be like a very realistic hope. Okay, so what are the chances? And to be able to say that it's really hard to predict the outcome, as we say, and that's where we always say there are many factors, some that the doctors know and some that the doctors cannot really talk about or know of. But we can definitely see signs. If you see signs, I mean, don't say, if there are zero signs, then don't. If it's a bad embryo, then don't say, we don't offer hope there, but you offer some different kind of hope there. But to be able to say we see signs and we will continue to support you through every step. And something very beautiful just came up in the earlier talks on how much to inform and what to inform. What is within the realms of what you should be saying? Not something which is too clinical, but something that actually is the intersection of hope and information. So give them the information, like I said, give a very informed and a compassionate hope. And compassion, I think, is the key ingredient of our work in our lives, not only as doctors, but as human beings. I mean, if we were not, if we didn't have that ingredient of compassion in us, we probably wouldn't have been in this profession. So, some amount of wanting to help, wanting to give of yourself, wanting to share your skill is something that all of you really signed up for and took that oath. And so, hope here is not the certainty, but actually, it is helping people tolerate the uncertainty. So that is the hope. That is really that little space between what is realistic and what is hope and what is informed and what is still something that they can look up to. So it is helping people tolerate the uncertainty. And so each time, when you're really talking to people, I mean, it's they may be hopeful, they may be also very disappointed, but empathy is something which is the core of all communications. So when a patient comes, my formula is that even if you are giving them 10 minutes of your time, I know you all give a lot more, but I've also had the experience where sometimes doctors do not have genuinely don't have the time, so they can't give you more than 8 to 10 minutes. But make sure that those 10 minutes are very, very valuable. To begin with, they are compassionate. They reach out to the person. Just that smile of yours, you know, actually calms the person down. It takes away their anxiety, because understand that people who are coming to you are very anxious. And these days, you will also have a bulk of your patients who have read so much, and who have already used ChatGPT as their doctor, have run through many information, have made several points, will have 100 questions for you, even if you don't want to answer. you know do not let compassion leave you. Just pick up what is behind those questions. They're not testing your knowledge. They're actually just so anxious that they want, every information from you. They're actually looking for validation from you. They're looking for hope, they're looking for validation. So when you're really answering, or even if you're not wanting to answer, it is all right to say that ChatGPT has a certain way. It's good that you are interested in, you're so invested in having a baby, and it is good that you have these questions. However, for these questions, I am going to refer you to XYZ, maybe one of your juniors or somebody who can answer those very regular questions. But from you, they really need that. What is it? So what does it look like? Will I have a child? Will I be a parent? Will this work out? So your empathy formula, I'm going to give you a formula, believe it or not, is very simple. Acknowledge the anxiety, as I said, acknowledge their need to have a baby. It's a very normal human need. We all want to be parents. Those of us who choose to be parents, we want to be parents, and we really want to be parents. So acknowledge that it's a very normal need. And if people have come to you, they've obviously come to you after several years of trials. Acknowledge to say, I understand your need to be a parent. Validate what they're feeling. It's normal to feel anxious. Then give them information about what, like I said, if it is two good embryos, can you say that here are, two good embryos available? Let's discuss what that means. Or very clinically, you could just be saying, oh, we've only got two embryos. Now, there's a difference. The moment you say we've only got two embryos, it can actually fracture the hope of your patient. But if you acknowledge, so in a way, I'm sort of suggesting, with all due respect and very humbly, that we must rewrite the clinical language. So instead of saying, you've only got two embryos, or one bad embryo, whatever you want to say, transform it to saying we have two embryos available. Let's discuss what that means. So let's just see what that could look like, and then give them the information. Or like whatever, when you have to deliver a difficult piece of information, whatever that information is, if you add compassion to it, it results in trust. Information without compassion is cold, is heartless. And information that does not have compassion can actually, and there's only compassion and there's no information, that can lead to confusion. So you need the information to be given, but with compassion. Like I gave you a small example. And in your own ways, that there will be many, many spaces where you could be looking at your patients and just seeing that hopelessness in them and wanting really to do something. And it's like, like I gave you the example of my friend who was disappointed because even though her brain knew that she could not do much about this baby, but she carried that disappointment. She had a lot of questions in her head, and actually she broke down. Now, I'm sure you may have also sometimes carried the patient's disappointment with you. And a lot of the times it may be told that, look, our job, you as doctors are not gods, but you're very close to God. For patients, you're very close to God. So people may also say, be detached. Yes, be detached from the outcome, but don't be detached from the people. Each one of you is deeply committed to the process. So bring in mindfulness as a technique over here to be detached from the outcome, but be compassionate with the people. So if I were to really describe mindfulness, it would be, the ability to be fully present in the moment, whatever that moment is. And because, when you're fully present, I mean, a mind is there's a conundrum in the mind. If we can somehow quieten that, and if we can just bring our attention to in the here and now, just your conversation with your patient, what it does is mindfulness actually, in a very simple way, is just to allow yourself sometimes to just sit and watch your breath. It's the simplest technique, just watch your breath going in and coming out. Sounds very simple, huh? Very hard to really to stay with it. But mindfulness, it gives you, of course, better concentration. It also leads to fewer errors. It helps in emotional regulation, yours as well as the clients, the patients. I mean, we call clients in our lingo. It reduces the stress for you, and it reduces the stress for your patient. And therefore, there is a higher chance of an improved outcome. I don't have any figures for it, but I'm sure that all of you anecdotally can actually tell me that patients who have come to you with hope, with a lot of positive demeanor, and sometimes you've been surprised at how positive they are, but you have been able to help them because their positive attitude has somehow rubbed off on you, and you've said, let me help this patient in whichever way. And you may have come up with some kind of, if I may call, creative solutions that you may have even surprised yourself. So yes, I would just sort of say that, excellence in your work can actually happen, when you're able to just combine your scientific precision with human compassion. So, I mean, if I were to really say that this work seems it seems like a load of responsibility on you, because you're not just carrying hope, you're also handling their disappointment. Well, I mean, not every situation is going to work out. And if it doesn't work out, their disappointment, their anger, their hurt, their pain, their hopelessness, everything probably also comes on the doctor. Maybe they doubt and say, oh, maybe the doctor didn't do a good job, because it's very hard for them. And when you have compassionately worked with the doctor, with the patient will always say, my doctor tried everything. I couldn't have had a better experience. And all this can be very heavy on you. All this can be very difficult. So, counseling is not just compassionately speaking to your patients. Counseling is including empathy in every interaction. Counseling means even if you're giving them, and that's something that I have data on, right? It has been shown that there is a change in the biofeedback even in a 6 to 7 minute of interaction. And surely that time of yours can give hope, can give a peace of mind, can give some kind of possibility of bringing a smile on their faces, even when the outcomes are not guaranteed. But just because, it is, I remember this quote, I think it's Maya Angelou, I'm not sure, but, it says something like, people may forget what you said, people may forget what you did to them, but people will never forget how you made them feel. And that is very much in our hands. Just a few minutes, starting with a smile, asking what brings them here, validating, yes, it's a very natural need, maybe a little bit of a humor in it. All of this goes a long way in calming the patient down. And even when you're very, very angry with the patient, you know, try not to bring out that anger, but in a very kind but firm way, be able to say, there are a lot of people waiting, and let us just do justice to the time we have. I'm going to ask you some questions, and I need you to give me as accurate an answer as you can. Okay, that, when you do this with a patient, it emotionally regulates them, and it emotionally regulates you. It's a very simple thing. This is also mindfulness, when you just sort of say, okay, and for you, I'm going to come to self-care, because I know my time is probably getting over. But the self-care is extremely important for you, because your role is fraught with a lot of expectations. A lot of expectations from self, from the patients, from the community. You're being judged by your entire fraternity. Also, everybody talks about success rates and so on and so forth. I know it happens in my profession, so I'm sure it happens there as well. But your care, your self-care is not selfish. A good doctor told me that doctors, especially surgeons, their lifespan is a little lesser than ordinary people, right? But that's a bit scary. I think self care is extremely important. And self care, I mean, just at three levels. At the physical level, you're good doctors. Your sleep is important. Your nutrition is important. Your hydration is important. Your exercise is important. Your relationships are very important. Okay, having some kind of relationship is very, very important, because that actually adds to the longevity, and that helps you deal with a disappointing day. Yeah. The second thing is the emotional one, which is when you have difficult cases, please take out some time and debrief. Create a structure where you can debrief amongst yourself. Seek support from your fellow professionals. Do not hesitate in asking, this is a difficult case, how would you deal with it? Reach out to each other, not just for emotional support, but also for information. And the third is cognitive. So physical, emotional, and cognitive. In the cognitive, I think, take tiny, tiny breaks, micro breaks. Even, a 2-minute reset of breathing in and breathing out can actually help you focus better, can actually relax your mind. Manage your overload if you can, if that's a possibility. But if it isn't, make sure you have micro breaks. Make sure the fourth level, which is the spiritual level, which spiritual, I don't really mean, I'm not bringing religiosity here. I'm not bringing any particular spiritual practice here, but I mean it in the larger sense of the word, the concept of mindfulness, the fact of being in the here and now, not really trying to predict the future, not really seeing the past, but in the present, what does this look like? In the present, what does my moment, this moment look like? So for me, this moment with you is the precious moment because I got this opportunity to share some of the skill set that I have. And more importantly, I've had the honor of being a part of such a wonderful fraternity, which is offering hope actually which is actually helping people birth humans. And that is really something that is larger than what any one of us can envisage. And to bring the element of compassion and counseling, I think will make this work even better for all of us in this community. And I think the universe could do with a little bit more passion. And so please go ahead uh, and do the good work that you're doing. Immense gratitude to you for doing the good work that you do. Many a times it's unacknowledged. Many a times we are the harbingers of a lot of pain of people, but all the same, you still carry on. So thank you for the good work that you do, and thank you for this wonderful opportunity. And I sincerely hope I haven't overstepped my time. Thank you very much.
Thank you so much, ma'am, for that insightful presentation. Actually, it was indeed very meaningful and valuable. Your small suggestion about your empathy formula, your breath control suggestion, these are very practical and doable things which we can really practice in our routine practice. And your talk reminded us that effective communication in ART is not only about giving information, it is about listening with empathy, understanding emotional distress, and supporting patient through the moments of hope, uncertainty, and disappointment. Building on these principles, we now turn to a very relevant question: should clinical embryologists communicate directly with patients or not? For that, we have Dr. Rajvi Mehta ma'am with us. And before we begin ma'am's presentation, it's my privilege to invite Dr. Poonam Nair ma'am. May I have her CV, please? Aarti, may I have Dr. Nair's CV, please? Informally, I'll introduce that Dr. Nair. We are inviting Dr. Nair, ma'am, for opening remarks for this talk. Dr. Nair, ma'am, is a mentor of IFS SIG, counseling and psychological support with more than 25 years of teaching and research experience, integrating mind-body approach with standard care in psychiatric disorder in IVF treatment. She has been closely associated with IFS initiative on counseling, psychological care in ART, and academic publication in this important field. Ma'am, may I request you to kindly share your opening remark and introduce this important session. Over to you, ma'am.
Good evening, and thank you, Dr. Vinder. It was a very beautiful and a very sensitive presentation, and it highlighted a very vital aspect of any human being, whether it's the clinician or the patient, is their compassion. And if I may say so, that if the clinician is coming from a place of disturbance, again, we are all human. There may be family issues. You may have rushed through traffic, noise, and handling domestic pressures, situations. And like in one of the workshops, the clinician remarked, "Oh my God, the same patient again, she's always complaining." So, with all due respects, I think perhaps the first look is within our own selves, that when I'm entering my professional field, Am I aligned truly with my own core inner humanity and compassion? Have I somewhere forgotten this in the rush and bustle of life and things? So, that self care, mindfulness, yoga, meditation, it is absolutely essential. It is like we say psychological hygiene, like we take bath, brush our teeth daily without conscious effort because it's so inbuilt in us from childhood. But psychological compare and care or spiritual hygiene, it is something which maybe we need to develop consciously, especially in a patient care profession where other human beings are so vulnerable, and sometimes in their anxiety or in their aggression, they react in ways which are not really normal, I would say. Like there's so many cases of violence against doctors, which is so sad. When I was working in MAMC, I saw bouncers on the gate. I said, my God, where are we? Where are we going? So here, the doctor, perhaps, if the seed is in them of self-care, I think that probably it's like a seed which grows, blossoms into flowers. It automatically translates into compassionate practice to a large extent. So thank you very much, Dr. Vinder. You've really put in the point very powerfully and very effectively. And I would like to here address specifically the ART field, where the patient is primarily not looking for compassion, is looking for a baby. And at times in the initial stages, even to get them into the point of emotions and psychology and all those relationship dimensions, we need to process it through the channel of you have come to ART for the baby, you need a healthy body and mind to hold the embryo which is going to be transferred. It's your body, your mind, which is going to carry this through. So half the job or a large part of the job taken by the clinical team, the nurses, the embryologists, the staff. The other major part is you yourself, how you are handling your levels of stress, and then a bit of psychoeducation about how stress impacts the body, especially the reproductive system, which is totally on the opposite extreme of stress. Reproductive function is not optimal unless you are in a relaxed state. So, I mean, almost intuitively, when I see a patient, I can feel like this person is going to have a difficult time conceiving because she is saddled with stress. So, somewhere to hook them out, I mean, that awareness that stress is actually going to contribute to their reduced success rates when they are spending money, time, effort. So this aspect of patient going into their self-care is equally important. And the feeling of we are not helplessly under the scanner of a technology, big machines, big terms, very qualified, they're overwhelmed. So they think, okay, we have, they are going to do everything. So empowering them to understand that they are a very vital role in their whole story, in the whole narrative. Now, for the embryologist, I think like Dr. Avinder said, that we have to address the cognitive needs, which are very, ASHRI guidelines has said that one of the most fundamental need of a ART clinic is to properly handle their need for information. They should understand the path. Where am I headed? And if something is going wrong, why it is going wrong, what can I do? What can the clinician do? So that at the end of the day, even if there is a failure, that feeling that the team tried their best, the embryologist did their best, and everything is not in our hands. There are things way beyond the medical team and life. The universal intelligence is at play. So we talk about spirituality in that context. Now, if I may say, Dr. Rajvi, you are an expert as a counselor. I think maybe you can tell to the patient, what are the fertilization results, about embryo development, day 3, day 5, 6, blastocyst status, number and quality of embryos, cryopreservation details. So all these things will help them understand that you are actually engaging with them in a very ethical, very scientific, and in a very correct manner. You can explain them the lab procedures, what will happen on the day of the retrieval, ICSI or IVF explanation, safety, handling timelines of the embryology. And you can clarify technical questions like what grade means, why some eggs don't fertilize, what blastocyst expansion stage means, and reassurance about the lab process. So here, the communication actually, this communication, this truthful communication actually builds trust, reduce anxiety, and humanizes the lab. But maybe the embryologist should not communicate the prognosis. Maybe recommend any treatment change, dose, protocol, interpret hormone levels or ultrasound findings, even provide psychological counseling when there's a loss of the embryo, and discuss sensitive issues like marriage, sexual history, or domestic violence. And do not convey bad news without clinician, the counselor, or the other support staff present. So we are talking that the clinician has an expertise, the embryologist has their expertise, the counselor has their expertise, and perhaps the each group should recognize the boundaries as well as where they should not foray into the other in case there is an erroneous or misinterpretation by the patient. So here I think I would like to, request Dr. Rajvi to give her ground reality experience being an embryologist.
Thank you, Dr. Poonam, for the opening remarks. So I am an embryologist to the core, but I do believe that infertility is an emotional disorder. And when I make that statement, I'm sure all the ART specialists, my fellow embryologists would think something's wrong with me. Infertility is a reproductive disorder. Why do I say it's an emotional disorder? Because if you were to classify disorders by symptoms, then what is the symptom of infertility? It is emotional. Does it bring any physical pain to the patient if they do not have children? Maybe endometriosis gives them pain, but then endometriosis is not the sole cause of infertility. And that is why I have always had this interest, although being a biologist to the core, in the human aspect, or what we would call the humane aspect of ART. And for a long period of time, and thanks to Dr. Poonam, although I've been a part of the IFS SIG holistic health for a very long period of time, we did many programs with Dr. Poonam, and I'm really happy that we are continuing that with the IFS. Now, I will directly go to the topic which I have decided to speak on today, and that is, should embryologists communicate with the patient? Now, classically, if we talk about the embryologists are conventionally backstage artists, and I really use the pun intentionally. We are artists, but we are backstage artists. We are generally away from the limelight. We are working in isolation in the culture room, often not with full lights, and we are silent workers. And most of the time, we are asked questions: how many oocytes, how many eggs, quality of embryos. But although being backstage artists, no activity on stage can happen without the backstage artists. So yes, we do not have to say, I think everybody knows how important an embryologist is. But should an embryologist communicate with the patients? And if you ask how many embryologists do really communicate with the patients, in India, very few embryologists communicate the patients. And in most cases, it would be the senior embryologist or an embryologist with a medical background. When I talk communicate, it's a very vague word. You can communicate as talk little, or you can have an intense conversation with the patient. So it is a very generic, very wide term. but mostly embryologists have limited interaction with the patients. Now, having said that, why do embryologists have such limited interaction? First and foremost, as embryologists, we have very limited knowledge on the history of the couple. We may know that this is the X cycle, but we will not know about the detailed medical history. We definitely would have zero idea about their emotional vulnerability. Today, mental health is a big issue, and couples themselves would have certain mental health issues with anxiety and depression, irrespective of the treatment. And the treatment is going to aggravate that. And I remember Dr. Poonam's in one of the presentations talking about how anxiety and depression nearly triples after a failed IVF cycle. So we do not know if the patient is in the threshold of an emotional highly vulnerability. So whatever we talk, we don't know what that emotional impact is. Secondly, most of us come from basic science backgrounds, and our training is in the labs, but we have very limited training in patient communication, which a counselor has and the medical doctors have. Because clinicians, right from their internship days, are with the patient, so they're very clear of what is being done. Now, there could be a big risk, and many clinics do not want their embryologists to talk to the patients because they are worried about the discrepancy in information communicated by the embryologist or, with the different team members. Not that one is lying or hiding something, but the way it is said. And many clinics prefer a one-point contact with their patient rather than everybody. So only if a patient needs a counselor, they are sent to a counselor, and need in the sense if they find them difficult to handle. Now, with that, I go to the next thing. Oops. So if I say, should embryologist counsel, many of my embryologist friends would say we are really busy with all the technical work, with right from the screening to the ICSIs, to the cryos, and then all the documentation that we need to do, and the administrative roles and the management roles, in the sense we may not be technically managers, but we need to make sure our media is there. So why do you want to add this additional role to us? Not everybody likes to interact with the patients or the time that it may take. So the reason I say, while should an embryologist communicate with patients, it gives confidence to the patient. The patient is talking, or the couple is talking to the people who are handling the embryos firsthand. And that confidence is different from us giving the information to the clinician who is going to communicate to the patient. So they really feel confident when you tell them what it is. Secondly, it impacts the clinic's functioning, because the embryologist, instead of being backstage artists, we are all humans, and most humans like a note of appreciation. And if the note of appreciation comes only from, the few people around you, but more people, obviously there is a lot of cohesion within the clinic. And it also motivates the embryologist when the gratitude the patient shows for the work you have done. Now, there is a embryologist communication. There are the pros for the patients. Like I said, it's the first hand. And like, Dr. Neena said earlier, and even Dr. Poonam and Dr. Arvinder, patients see the embryos as the potential baby. And here I would like to narrate an example which goes back to the 80s, when it was one of the first few cases that I was observing as a student. And what I found was, so we had a culture room, a glass door, and the lab. And I was working in the lab. Those days we preparing medium and doing all kinds of work. And talking of the days when there were no cell phones. And this patient comes with a camera. And after ET, so those days patients were asked to lie down for 3 to 4 hours. The husband keeps on taking photographs of the incubator. And I was a little surprised, because at the time of the ET, my clinician has said they're average embryos, but we will transfer them. And here I would like to reiterate that this entire program was free. And moment the patient started taking photographs, and he took the photograph of the incubator. And I said, what are you doing? I mean, I just asked him. He said, I will show my baby his or her first home. And that hit me hard, that how much expectations they have. And that made me so much committed that I cannot afford to lose a single oocyte. It is something much more, because then you didn't see it as an embryo, but you saw it much more an oocyte, but you saw it as a potential baby. And it gave me jitters and sort of made the whole thing situation of the way I worked very different. And of course, as far as the patient is concerned, it boosts their morale, it gives them confidence. Like I said, they feel comfortable that the person handling their embryos, they have confidence with that person, so things change. Then we go to this, that the pros for the embryologist, like I said, recognition and appreciation, and we are all humans, you appreciate it. I think it makes a much more responsible behavior from the embryologist. Now, why do I say that? Today, we have all the young embryologists who are very keen to do ICSI. They've just graduated and they're very disappointed within the first month, where nobody's going to allow them to do ICSI, that I'm not allowed to do ICSI. So I asked one young embryologist that, have you done it during your master's? A little bit. Then were you confidently doing it? She said, yes, I am doing it. And they're working with mice embryos. But when my sir stands behind me, I get nervous. Then I realized that when you're working, you need to realize that there is a lot of hope and responsibility. It is not just a cell. And when you meet the couple in front of you, their hopes, their troubles, their tribulations, I think our work becomes much more responsible. We get much more committed to their work. I'm not implying that we are less committed, but the commitment changes, because when you see the pain of the couple, you cannot take anything lightly. And of course, it enhances team spirit, because everybody takes the recognition as well as the failure together, rather than what it happens sometimes that it's a blame game. The embryos didn't grow or they didn't implant. Was everything right in the lab? And that's something no embryologist wants to hear. And therefore, embryologists want to document that I created the embryos, my job is done. However, let's remember, the patient doesn't come for embryos or blastocysts, the patient comes for a healthy baby. And that team spirit is essential, which is very, very essential for work. Now, the concerns. Why an embryologist? Like I said, we are not trained to communicate, and we have to be very careful about giving over information. It has to be very factual. You cannot go on describing the PN, you cannot go describing the morphology of the embryo, you can't talk about multiple pronuclei and all those things, but because or use too much of scientific jargon. The patient reads beyond the jargon, and therefore we have to be careful, and it can diminish the morale of the patient. They pick up some word, and then they will Google it and then come back with some kind of their own understanding. When it comes to the concerns, is the embryologist can vent. See, we are in a team, and it's not always that all the team members share the same viewpoint, but we come to a consensus, we come to a decision. Now it is, or sometimes if the embryologist has some issues, it cannot indirectly come to the patient. Oh, I told them this and they did this. Secondly, a lot of embryologists may divulge too much information, which is not to be done. And, because in case we talk of, sometimes there's personal insecurity. Oh, I did my best, the oocyte quality was not good, maybe because of the stimulation. So these kind of things should never, ever be spoken to the patient. So if you talk about communication, we are talking about a balance between objective dissemination of information. Information is factual. X number of X oocytes retrieved, X number of, whether we have got the good quality sperms, what is the fertilization, what is the quality of embryos, and explain that, but also a subjective human understanding of the human emotional frailties. Humans are emotional, and we have to be very careful of how we present the work. Now, patient communication skill cannot be taught in a classroom or lecture halls. We can listen to n amount, but it can only be learned by experience. And I think by shadowing a senior, observing the senior, it seems very common sense. But the way, the demeanor, the way you express yourself makes a lot of difference. So what we need to train embryologists, if we want them to communicate, is when to talk, what to talk, and how much to talk. Because it is, we may say a lot of things, but what is important is what has been heard by the couple. Because I have said, and we all know that even when we listen to lectures, have we grasped each and everything that the speaker has said? There may be times when our mind wanders. So what is heard is more important. And sometimes what is not said may be heard. You may say something, but the patient can imply that you meant something. So it is a very much a balance between talking and listening. And in the listening, you'll gather how much the patient has heard. Now, basic terms, yes, confidence. If I myself am so shaky, how am I going to transfer confidence to the patient? If I am very sloppy and I am rambling, then the patient is not going to have confidence and say, what is this person going to do? Humane. Let's treat the embryos as what we said, as a potential child and not embryos. Patients, it has already been said, a couple may ask the same question 5 times, and I think it's a duty to explain. Because the first time you have said it, they have heard it, but they have not registered it. Second time, they may have registered part of it. Third time, they may register the whole thing. So realize that it's routine for us, but we need to have the patience. And then whenever things fail, because they're bound to fail in a large number of cases, it should not linger into our minds, and we possibly can have a separate presentation on how to be in the present and not get affected. And finally, I would say what one should talk. So very objective and factual. A regular update helps. So therefore, although many embryologists do believe that we should just do fertilization or ICSI and go to day 5, I do believe that a quick look at the embryos on a FERT check, day 3 check, would actually help us to give the factual update to the patients. And that prepares them for the outcomes. Also, it's how we present. Information will be the same, but how we present. So if we say we are going to have a 60% success and 40% failure, the patient may read the failure and they register failure. And I think even when we talk, because for a patient, the percentages have no meaning. We are not giving them 60% baby or a 50% baby. We're giving them 100% or 0%. So even when we have a lower percentage to talk about, even in such cases, like we say, I have only one embryo or one blastocyst, but yes, that's one that is required, and there is a likelihood that can implant. So let us be very factual, positive, and show positive side of things. Now, what not to talk? I think we should not discuss the data of. I think it's absolutely mandatory. We do not discuss about the data or results of fellow patients. No judgments. Let us not use any adjectives while discussing very good embryos, beautiful blastocysts. I think the adjectives should go away. It's a blastocyst, grade A. Grade A means this, this, this. Also, we should never share the viewpoints or opinions of team members. The team discussions are meant for the team, not for the couple. And we should not even go and divulge and become super honest by saying minor errors. Now, there are errors which will not impact the outcome. There are things that happen. We don't need to go and talk about it or any technical details of the procedure. And be very careful. The patient is listening to every word we say, every expression we give. So any casual comment is going to be held by the patient. So be very cautious of what to talk and what not to talk. Then there are difficult scenarios like, you'll have things which we don't anticipate, total fertilization failure, no cleavage, no blastocysts, no embryo for cryopreservation, abnormal PGT outcomes. This is not something we expect totally. And then how do we handle it? So the patient's reaction when there is failure is shock, because nobody anticipates total fertilization failure. And suddenly the day 3 embryos don't grow further. And it's at the end of the story, because they do anticipate till day 5, and they do feel that the pregnancy test is where the problems are going to occur. And supposing the embryos are not good, there's a feeling of guilt. Oh, the eggs were not good. So we don't want that. And when you talk of abnormal PGTA results, their major concern is there's a genetic abnormality, and whether in future they'll get a normal child. And even in that case, whether the child will be genetically normal, even if the PGTA is normal. And supposing there is a laboratory error, ensure that the immediate reaction of the patient is going to be anger. So what should we do? We have to, again, I repeat, we have to become scientists first, be factual. And I repeat, no technical jargons, answer all the questions, and then give them time to receive the problem that has occurred, the failure that has occurred. And maybe a best answer would be, we will study the case and get back to you with what can be done in the future, rather than give them solutions immediately. And maybe at that time, statistics play a role. That yes, such a problem does occur in X% of the cases. Maybe you fall into that. We'll see what is the cause for it, and then go ahead and see what we can do so that you fall on the positive side of the thing. Now, it is always better to do this in person. it's not nice to do it on phone unless the patient is, because especially the first 5 days, the patient is bound to be there. And it's always nice to do it. So it's not the embryologist alone with the clinician. So it is that the whole team is supporting and looking at your case, and be involved in the conversation. Sometimes we may be genuinely involved, sometimes we may not be genuinely involved, but at least let the patient feel that you have done the best, which you have, obviously. And at that time, the patients are in an emotionally high state. Let us not give them a lot of advice at that time. Just let them accept, first of all, know about what has happened, accept it, let them digest it. Then comes the future course of action. So I would say, now coming to the emotions of the embryologist, obviously when there's a failure, the embryologist is equally disappointed. And as I always say, the patients see it 3, 4, 5 times in their life. We see it 40% or more times in our life. So naturally, we are going to be more affected than the patient. Now, one is we can totally be distant from it, not get involved. Why should I get involved? It's a patient. I've done my job. I don't think we are robots. We have to be emotional about it, but we should not get the emotions affect us. And again, that's easily said and done. If we get too distanced, then our work becomes mechanical, and the humanness is required, although we don't need that human touch when we are doing an ICSI. But today, remember, when we are talking of robotics, we are talking of automation, we are talking of the next 5 years of automation and AI. It is our approach that is going to make us good embryologists. So there has been only one paper where they have looked at an embryologist as a counselor. I intentionally did not use the word counselor because, it is a very loosely used term. So I talked about an embryologist as a communicator. And they did a small study, and it's many years ago and published in RBM Online, where the study group, where the embryologist interacted with the patient, and in the control group, only the clinician. And they found that the anxiety of the patient was reduced in the study group on all the 10 scales that they used. So embryologist counseling does reduce the anxiety. We talked about it from a common sense perspective. Now we have data for it. So with this, I would say that soft skills are gaining importance in the future of automation and artificial intelligence. It's the softer skills which will be more crucial. And with this, I end my presentation. Thank you. And I hope as a part of ACE IFS initiative, we would be able to do more of these kind of activities for the embryologists themselves. So over to you, Manisha, for the next part of the program.
And
Can I just, I needed to log off as I have something.
Okay.
So I was just wondering if there are any questions for me. I can wait on for a couple minutes. Otherwise, I'd just like to log off and say thank you so much for the opportunity.
thank you
Can
so
I
much,
can
ma'am.
I have a very vital question here. When we are talking about psychosocial care, whether it's the clinician or the embryologist or the nursing staff or the counselor. Now, ASHRAE has very clearly stated there is something called routine psychosocial care and something called specialized psychosocial care. When I see a patient who's been through treatment failures, so that person cannot be handled just by communication. He needs individualized, personalized care. That is the domain of a trained counselor with psychology background, where that means allowing them to ventilate, catharsis, support, and then going to the roots of their emotional distress. It can be a 3 or 4 week long process. It cannot be a conversation, no matter how detached you are. And the basic fundamental fact is that if you start routine psychosocial care from the moment the patient enters the clinic, and a very vital part of psychosocial care is providing information. If every clinician tells the patient, we are going to take out the semen, we are going to take out the ovum like this, they explain sometimes using models. So the person has an idea about the pathway. Similarly, if the embryologist can also routinely explain to every patient, okay, this is what we are going to do, this is the lab. They don't have to go into the depth of the science, but a major pathway where their gametes will be handled. So that kind of preparation starts right at the beginning, even at the reception, the way the receptionist talks to the patient. Sometimes they are so insensitized, like they said, they'll tell to the male, go and give the sample. Now imagine a man with, how does he feel being told by a female receptionist? It has connotation of masturbation. He's supposed to go in the collection room. A lot of men get totally inhibited. They cannot give the sample in the clinic. So here, the sensitization has to be for the entire team, right from the receptionist, right from the nurses, embryologist, and every the routine psychosocial care, the human compassionate part. It has to be like a reminder on the posters, even in the clinic. And the ASHRAE then says clearly that when the person is tipped into repeated failures, when the explanation for the failure does not exist, it does not exist. So here, there has to be a special time allocated to the patient, to the couple, where the embryologist, the person who's expert in genetics, the person who's expert in the clinical aspect, can collectively pool in that this is all that we tried, and give them time to emotionally process that the best of scientific knowledge was offered to them. Earlier, they came with 0%. We were hoping for 40%, but statistics mean nothing to one couple. Even if it's a 99% success rate, he could still be that 1%. So the trust, the human aspect has to be at every step. But like I've had patients asking me, the doctor's ka galti tha sara, because there was a miscarriage with twins at the 6th month, and she's consistently blaming the clinician. I'm not a clinician. So I went back to the clinician. I said, okay, they are human beings. There can be an error. So I understood what happened, and I went back to the patient and I gave the details. Similarly, there was another case. She was violent, like, I'm not going to leave here. This pain hasn't stopped to me since the C-section was done. The case has been messed up. And she was literally like dharna de ke baithi hui thi. I said, okay, we did a relaxation with her. Then I took the case up again with the person who did the C-section, and the case actually went to Dr. Neena Malhotra. I said, please, we have to understand how to help this lady. She's in suffering. She can't pick up the baby. There's so much pain. She can't nurse the baby. She can't have normal relations with her husband. So the case was put up in AIMS discussion as a case study. And finally, we got the answer, and that was offered, and the patient accepted and calmed down. She knew it was not the clinician to blame. So sometimes I recognize my boundary as a counselor. I cannot answer specialized questions which the patient is throwing on me, and patient ventilates on with counselor full on. Iski galti thi, isne aise nahi bola. She did this wrong. I didn't like the way, so many things. We have to respect every query.
Thank you
Because
so
this
much,
is the person. Yeah,
Poonam,
thank you.
thank you so much for bringing that very important aspect that, not all specialized. Here is my take on it exactly into sentences. I think all of us, for the most part, each one of us as doctors, as patients, as everybody, we can do with some kind of compassion and psychosocial kind of healing as soon as we meet. And I take your point absolutely 100% that all nurses, all staff, everybody has to be trained in how to really just treat people. And I think how that starts is it starts from us. So when we talk to them in a certain way, we encourage them to be that in a certain way. It's a culture that we build with organizations that work with how to build a culture. And I think that's what you're talking. Thank you for that. And also a very important point of the second part, which is some cases which are not in the medical terms crisis, but kind of critical cases which need a little more kind of focused work, which can be referred to different spaces. And I think we need to have, I think Dr. Rajvi and I had a very interesting discussion on that, on how, this aspect needs to be developed on where these people can be referred if they need further help, so that it does not add to the already heavy burden that you all are carrying. So I take that point. I think there's a hand up and I'd like to answer that question.
And if I may say that when we are now talking about having a counselor who's an integral part of the clinic, like an embryologist,
Yeah.
because the counselor is seeing the journey from beginning to end, a 4 years journey they are seeing
Yeah.
happening, unfolding,
Yeah.
and they know their connection with the patient is actually deep. But when we outsource the patient to some other place, then for them to really go through the medical aspect as well as the detail, it's a very technical
No,
field,
but we can,
and
there
fuse
can be a
it with
little bit of a
psychological.
segregation, and there can be the
Mm.
emotional aspect which can be handled. But I think in the interest of time, maybe we should have this conversation offline. I would absolutely love to
Yes.
engage with that and see,
Yeah.
brainstorm on
Yeah.
that, see where we can take it. I think Dr. Vishal's
Yes.
hand has been up for some time.
Okay.
Thank you so much, ma'am. This conversation is really, really important, and we all understand that need of a counselor, because in infertility we are dealing with lots of emotions, anxiety, and a counselor is must. But today we are specifically focusing on, because people now want to interact with the embryologist, how to train embryologist for delicate communication. So your inputs are really appreciated, and we'll be having a detailed discussion on how to nurture a unit which is empathetic to all these patients, definitely, but time crisis is there. So we will be taking all the questions from the audience in upcoming open forum. And thank you so much, Rajvi ma'am, for your thought-provoking presentation. Your practical guidance helped us to understand how embryologists can communicate with patients with clarity, empathy, and professional responsibility, while also maintaining appropriate boundaries.
Excuse
Thank you
me,
so
ma'am.
much.
Sorry. Yeah,
So
sorry to interrupt you, ma'am,
yeah,
Dr.
sorry.
Ma'am.
Yeah.
So my question is to Dr. Rajiv ma'am and Dr. Singh ma'am. So I have already done multiple of counseling to the patients who is coming as a couple. They have done some failures also. They have seen as failures in our center. So what do you
No,
think about embryologist can have a both the role, like
We,
a embryology
uh,
role as well as a counselor
okay.
role?
So, Dr.
Is it
Vishal,
possible?
we have a special session where we are going to have Dr. Parsuram, who plays a dual role as a clinician and counselor. Sorry, as an embryologist, and Dr. Gaurav. So we will take these questions in the open forum, and then, of course, Dr. Poonam, myself, Dr. Sujata are here, and we'll also give in our inputs. So I think the question now, we open out the open forum, and Manisha, you can moderate that. Yeah.
Yeah, thank you so much, ma'am. So with this, we now move to most interactive segment of today's webinar, our case-based discussion, because we all understand communication is often tested not only in theory, but in emotionally complex situations we face in everyday practice. Through real-life scenarios, we will explore how embryologists can navigate different difficult conversation while maintaining scientific integrity, professional boundaries, and transparency. To guide us, we are privileged to have two respected leaders with complementary strength. We have Dr. Gaurav Majumdar, who is Vice President of Academy of Clinical Embryology. He is Chief Clinical Embryologist at Sargangaram Hospital. He brings a precise, scientific, logical, and equally focused embryology perspective. And with him, we are fortunate to have our Secretary General, Dr. Parasuram Gopinath. He is Medical Director, a known clinician and embryologist, scientific director at Simar Fertility Center. And he brings a rare combination of clinical expertise and same expertise in embryology, along with calm judgment and a deeply patient-centric approach. So what makes this discussion meaningful is the difficult conversation may be approached in different way with data, clarity, calmness, reassurance, and empathy, yet always with the same purpose to preserve trust and support the patient uh, always have in you. So With this, I would also warmly invite all our other experts present with us to share their perspective, wherever they feel they would like to add anything to the question. They can be part of this discussion. With this, may I share my screen?
Or maybe Manisha, Dr. Vishal had a question, so we can just
Yeah, so
start.
we'll start with this.
Okay.
So, Dr. Vishal, if you want, you can start with your question. Dr. Vishal, are you there?
Yeah, yeah. So my question is that the patient nowadays is having, they are very eager to know about the status of the embryo, why failure came, and also the grades. If actually we had a three embryo frozen, and the one is good grade, which is of A, and another two is grade of C. So the A grade have been transferred, and it unfortunately came negative. So when the another two, our clinician feels that we have to go for a one more cycle according to her body response. But patient is asking to us embryologists, why not the C grade? We have to spend so much on another cycle completely. So in that such case, how we are going to handle a patient? On the another side, the ARTLA is very serious about of discarding of the embryos. Yeah, that's what my question. I hope this forum will help us very nicely. So when we are planning and we are explaining to patient that we are going to discard the embryo, the patient is again to asking to reverting back to us. No, 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 we have to transfer this. We want a baby. We can't go for one more cycle with all one more periods, and we have to take a hormonal injection. In such case, how we are going to handle a patient? Anyway, it's going to come to a embryologist is going to know why the embryo is can't going to be implant more than a counselor. I hope so. So I hope this question is very
Would
valid
you
and
like to take this up?
Yeah, I can just say here, since it's a pointed question on poor embryo morphology, that this whole concept of discarding embryos after initial failures, is probably something that confuses patients. And so, as embryologists, you have to be very clear that preserve embryos only where you know that these embryos have a reasonable chance of resulting in a pregnancy. Um, so that is something which is very important here. And you have to set their expectations uh, from the beginning about the fact that poor embryos don't, or embryos with low grade morphology. Let's try to avoid using the word poor because that really plays on the mind of a patient. So an embryo with an inferior grade or a lower grade can result in pregnancies. And also the fact that embryos with good morphologies doesn't necessarily guarantee pregnancies. So this is again, this is part of how the patient has been pre-counseled before getting into IVF, that we are going to take up now,
Yeah.
questions on that. Yeah.
And before that,
Vishal,
Dr. Sujata is
So,
also
Manisha,
there, and
yeah,
she wanted to ask something. Ma'am, all yours.
yeah. See, the thing is, I'm asking all of you here, Dr. Rajvi, Dr. Gaurav, and Dr. Parsu. See, in some centers, what happens is whenever there is something which is negative, say, for example, patient didn't have any fertilization or didn't have blastocyst or embryos transferred and no pregnancy, they are asking the embryologist to talk to the patient. So the embryologist goes and says the fact, saying like, you had this many eggs, we injected with this many sperm, we found the oocyte was like this, sperm was like this, no fertilization. But patient keep asking, give me the answer why it didn't, why. And sometimes what happens is, you may not have, say for example, if it was extremely poor quality sperm, but still you found some sperm for injection. So that is why they came here for, right? Like, you cannot explain all these minute this thing at the time of ICSI itself. Then they come back and ask, like, why you didn't inform us earlier whether we have to proceed with ICSI. So in such situations, how do you people advise embryologists to talk to the patient?
Ma'am, actually, with this is a beautiful question, and we generally face it day in, day out. So, I really wanted to start this conversation with this question. I'm combining my question. When should embryologist first interact with the patient? Dr. Parsu, would you like to take this up? What do you think? When we should start our communication with the patient? Patient.
See, I think from Vishal's, I'll just give a brief from what Vishal was asking. I think as a doctor, embryologist, or whoever it is, I think it is our job to give the patient a very realistic picture, all right, of what we need to do, or what do you think if we do like this is the possibilities, this is the possible success rate, this is the cost involved. If I do like this is the success rate, this is the advantages, disadvantages. And I think we have to leave that answer to the patient as to deciding from listening to you. So it is basically an informed decision making by the patient. So when like, you don't tell them that, okay, this, see, you tell them that results are lesser, and then if they are ready to take the chance, they don't want to go through a higher another IVF and go through it, you give that chance to the patient. Now, coming to the question here is regarding the like when an embryologist should communicate. And I'll tell you the situation, what happens in our center, or what has been a policy in our center since it started. The first time probably the embryologist interacts to a patient is after an home pickup, technically. Before that, all the counseling. Now, this might not be always right, but this is what in real time happens, wherein the initial counseling is all done by the clinician. They give you a brief picture of what has happened, what are your possibilities. Say every time a patient is counseled for an IVF, we always tell them, okay, what are your options? Okay, an IVF, if you're doing an IVF, what are your success rate? Very clearly mentioned as what is your success rate expected in your treatment. And once the egg pickup, everything happens, that is when the first time the embryologist interacts.
Now,
So
okay.
when the embryologist interacts, the first thing, obviously, the first time after home pickup and ICSI, it's actually after both. So they will give them these were the number of eggs that were received. These were the mature eggs in that. These were only so the sperms. The quality looked good or average, and this is what we are planning to do. We've done an ICSI here, so now we'll wait and observe it for the following days. This is what generally we always do. Like what madam said, I don't think when only a problem comes, you don't push the embryologist
Yeah.
in front of
Dr. Gaurav
the
here, I really wanted to
Uh,
take your views as well.
No,
When
yes,
no.
I
See,
agree. I agree
Parsu,
with that.
Parsu,
Yes, madam.
Okay.
Parsu. The thing is, no, the thing is, like, it happens in labs. So that's why I'm asking. So what would
Agreed,
you
madam.
advise?
Yeah,
Agreed,
yeah, yeah.
madam.
So
Yeah.
we are getting to that how to manage that situation. So like Dr. Parshu just said, at our center also, generally, Manisha, just can you go back to the first slide?
Sure, sure, sure.
uh, the embryologist talks, or there's a proper slot for embryologist counseling post egg retrieval. However, for the kind of question that Vishal asked earlier, if a patient is coming for an IVF after multiple failures or after having a long history, and when clinicians gauge that there's a lot of anxiety and a lot of questions where the patient has already gone through a lot, then they schedule a embryologist counseling before the case even begins, so that the patient who is very eager can discuss all possibilities of they have done that with the clinician, but they also want a word with the embryologist about what can be done in the laboratory. So sometimes before the case starts, especially for patients who've gone through multiple IVFs and then they are approaching your center. And otherwise, the best time for an embryologist to communicate with the patient is after the eggs have been retrieved.
And I think somebody did ask in the questions as to do we tell them about the quality of the egg after do an own pickup? But see, I think
Not really.
if not, then when do we tell them? That is another question.
No, so the standard answer that, because this is again a very this is a very logical question from the patients, that how are the eggs?
Yeah.
What do you think? You have seen so many eggs. How do my eggs look? Do they look good?
And
So
that was actually, I was about to ask this question as well, because this is a very common question. The moment you got the eggs and you have seen the semen, you have denuded the eggs, then they wanted to look how you see, what are the prospects according to you. And that is a very crucial time, because it is generally we are being introduced to the patient generally in lab when ovum pickup has been done. So
so
they come
generally
to
what
us, and that was the exactly question. Next question. In after OPU, the clinician sends patient to you, and generally they ask how many eggs did you get, and how good they are, and whether they can be give us good embryos. What are my chances? And that is a very crucial moment. You don't know much, and you don't want to demoralize them. So how to navigate this complex situation? What should be the balance counseling at that moment?
See, if you look at it, most of the time, what happens is no. I don't know if there is any embryologist going to say on day this thing, you got excellent eggs, you got excellent sperms. They'll say, yeah, you got reasonably good quality eggs, or you would say like you'll always play safe because you don't know what is going to come. See, somebody was talking to them regarding fertilization is on the day of fertilization is better. See, it is very difficult which day is right. All we can say is that yeah, we got a reasonably good egg, or we say that it's an average quality egg. The sperms are okay, the ICSI process went well. So we will wait and watch how the fertilization happens. We'll have to, only once we wait and we see the fertilization, we'll be able to tell you. That is what most of the time will tell you. Because again, giving a day-to-day update is something which I also don't, I personally don't agree. Because again, tomorrow you will see 2PNs, you're not sure, a 2PN disappearing, 2PN seen, then you will say, I'm not sure how many embryos. Then the day after tomorrow, again, you have to change and tell them that, no, it is actually 2PN which disappeared and now it is become embryo. So rather than giving them too much of updates, which is probably giving them bad, because see, we have seen n number of average quality eggs, or especially these PCO patients, or sometimes endometriosis patients. The eggs will be little average, and but then we'll get excellent quality embryos in them, and we get very good results also. It's not that we don't get results, but don't give too much of emphasis on saying that yeah, it is a poor egg, or that is what my thought process is.
May I add?
What we do in our center is, we this is the time for setting realistic expectations for the patients. For a patient who has retrieved 10 eggs or 5 eggs or say 20 eggs, now they don't know what's going to happen next. So this is the job of the embryologist to first educate them that not every egg will fertilize, and not every fertilized egg becomes a blastocyst, and attrition during embryo development is normal. So we break it down for them. So we tell them, for example, if someone begins with 10 eggs, then the average fertilization rates that we expect are around 70%. But what will happen in your case will depend on, how your eggs interact with the sperm and how well they fertilize. There can be a lot of variation, but on an average, 7 eggs would fertilize. And out of 7 eggs, then how the blastocyst development occurs. And in the end, we explain to them that so typically out of 10 eggs, we expect 2 blastocysts to form by day 5 or day 6. Now, we again emphasize that this is what happens as a standard average. But for you, maybe your response is above average or same as average, or could be also sometimes below average. So that is something that is the real challenge. And that will only be revealed in the next 5 or 6 days when we know how the situation has panned out, and depending on the inherent quality of your eggs. So again, we don't define eggs. We say the egg quality is only defined by the kind of embryos which are formed at the end. So, so it is basically the embryos are the reflection of egg quality. There's otherwise, it's hard to quantify them unless there is something grossly abnormal with the eggs. So this is the time when we take to set expectations, to be very realistic, so that they don't start thinking that 10 eggs will lead to 8 embryos or 10 embryos, and you tell them this is normal. This is normal. So when we have 10 eggs, then we expect on an average 2 embryos to reach blastocyst stage. And that really helps them put things in perspective.
Actually, we actually tell them about this while stimulation, sir, because they always understand, no, why do you need so many eggs? Why are you stimulating? Why, how many? You see, we always tell them, see, we always aim to get around 10 to 15 follicles. So if you have 10 to 15 follicles, you might only end up getting 10 to 12 good quality eggs. If you have 10 to 12 good quality eggs, you might end up getting only 7, 8 embryos. And in the end of the day, you might have 5 or 6 or 4 embryos or 5 embryos, which are of top quality. So ultimately, you use this much, only you get that many number of stimulation is how you will end up getting this. So I think that this is a continuous process. I think this kind
You
of
have to keep reinforcing
this because see, patients always will tend to hear only what they want to hear. See, that is always, see, how much ever we say that we have counseled them before, they tend to always hear what they like to hear, or
Always want to hear the positive side, and they'll
positive
stick
side.
on. And it is in
It is
a way
very
good,
difficult
so
to.
that they have that hope alive. Otherwise, they start. Yeah.
Manisha, so a very important part of setting realistic expectations is also telling them that when we perform an IVF, there is a 5% chance of fertilization failure. And then
Yeah.
you can tell them that 5% is actually very small, right? It means that in 20 patients, maybe one will have a fertilization failure. There is no way of predicting it. There is no way of knowing that something like this is going to happen. But we should not worry about it. This is only for you to know that
Yeah.
just getting eggs does not guarantee fertilization.
And
Similarly, we use a lot of data from our practice
that is very important.
to tell them stuff like, so they will say, so how many blastocysts am I going to have? So we actually use proper data from our practice to tell them that these are our blastocyst formation rates for patients who fall in a profile like yours with a similar age of as yours. Then we also talk to them about no blastocyst formation rates, where we tell them that for someone who has 15 or 20 eggs, we have a no blastocyst rate of 5%. But say, for example, for someone with 3 eggs, we tell them that there's a very high risk that we may end up with no blastocysts. With 3 eggs, this is one major limitation, with the science, that we cannot be sure. And so there is a risk, there is a almost 1 in 3 risk that we may not end up with any embryos, but we have to see how it goes. And so we are setting their expectations in a realistic realm, where they say, oh, okay, so 3 eggs is not very rosy, and these are the problems which might occur, but we will take it. We will see as it goes, right?
Right, absolutely right. So that balancing these things is the game actually. But Dr. Rajvi ma'am was there and she wanted to say something. Ma'am, are you there? And would you like to add something to this? Actually, generally in our practice, we always compare it with the nature. As in nature, every tree, every everything cannot be, every seed cannot be, cannot become a plant. So there will be some loss. That's how we compare this thing with the nature, and probably the same thing is happening. Rajvi ma'am is
Yeah,
there.
so
Would you?
basically, I was talking when Dr. Parsu said a day-to-day update. I meant just a factual update. And I totally agree that, we need to give all this information, what we're talking about, before. So they are prepared. Why so many eggs, like you just said. The only thing is, I think when we came to the specific point of oocyte quality, honestly speaking, unless they are highly vacuolated or with SCR, we ourselves don't know where we are heading. So
Yeah.
possibly the best simple thing to tell them is appearances do not communicate. They look, we'll see what happens. And I think, talk less is always better when it comes to information about gametes. That's all I wanted to say,
You
because
can just say visually they look fine.
yes, exactly. But functionally, we'll know tomorrow. And then,
Functionally,
it
we'll
goes
know
on.
tomorrow and in the next 5 days that how
Exactly. So the
robust they
little
are
we
functioning.
talk, the better it is at that stage, because they'll keep on. You said they were good, then why? So whether, they go into the loop and they make us get into the loop. So that's all I wanted to say,
So
Manisha.
the important thing is that on day of pickup, don't promise anything. Give the factual information and be limited there. The final things will be delivered after a few days, probably day 3 or day 5 is the better day to communicate all these things. With this, I'll move to the next question. If a patient comes to you and she is 34 years of age,
Hello, Tipu. हाँ बोलो बेटे.
good ovarian reserve, husband showing normal semen, first IVF ICSI cycle, 6
हाँ बोलो
mature
बेटे.
egg collected, uh, outcome discussed with the patient, day 1, 0 normal fertilization. You have done ICSI, no embryo to culture, husband is there, and they are obviously very, very anxious. She had every reason to expect good news, but she is now in shock. How to navigate in such scenario? If embryologist is there, definitely they'll ask you what was the reason of my fertilization failure. So how to mitigate such situation?
So again, you have to, convey the facts. First, you have to tell them that the chance of ending up with a fertilization failure with ICSI is very rare, right? And probably happens in about 2 or 3 people in every 100 people, right? So, so this can happen. This can happen, and this is an unexpected event, and one cannot predict it. It is impossible to predict it. No semen analysis or no amount of pre-testing can help you predict such an event. Because again, so you have to, break down this information for them, that even though a semen analysis will say that there is enough sperm and they look to have good morphology and good motility, but it doesn't tell us about the functional capability of a sperm. Similarly, when you retrieve eggs, like I think you said there were 6 mature
Yeah,
eggs,
yeah,
right?
yeah.
So again, like you said, that only during IVF do you understand what is the functional capability of the gametes involved. And then you also have to give them hope, saying that, and you can even quote, proper studies or figures from literature, that for patients who do have fertilization failure following ICSI, what is the future prognosis? That in the next cycle, how many of these patients will, end up having normal fertilization? And in how many patients will this problem likely persist? So these are the things where you can, you can probably break the information, both clinician as well as embryologist together. But also please recognize that this is a very rare event to
Right.
happen, and it may happen 1 in 100 patients,
Yeah.
right? So so they're most, so they may come to terms with a fertilization failure, and you may say that probably, this could be one of the factors which is responsible for the unexplained a kind of infertility that we are looking at. And there
But
is, yeah.
I really wanted to ask here because in such scenario, as you rightly mentioned, those are very rare scenarios. So generally, blames come to the lab. There must be how to prevent, how to prove that there was nothing hazardous from the lab side.
No, why should the blame come to the
See,
lab? Because
uh,
you are not performing cases in isolation, right? So maybe what you can use to allay fears of patients here is that a lot of patients are going through IVF cycles in the laboratory. And then you have to refer to the fact that anecdotal or an individual failure for a patient does not, because you have to tell them if there is something wrong in the laboratory, then
Maybe
that
group
will
approach.
reflect collectively on all patients who are
Absolutely.
undergoing IVF. But if everybody's embryos are fine and there is one fertilization failure for one patient, it means that it could be because of some, inherited problem, inherent problem in the gametes of the patient.
Definitely. Without
Manisha,
This
discussing
has to
the
be
Manish,
explained,
yeah.
very calmly.
right.
Manisha, I think there's something which I always follow in my practice is when something bad happens, a negative counseling, like see, first time when you break the news, what I always feel is that, okay, we give them a very clear picture as to, okay, this has happened. It's very unfortunate because I feel that first time, even they're also taken aback, they're shocked, they're also not in the frame of mind to actually absorb everything that we tell them. There's some completely taken aback, even if you say that you had poor embryos, we will try and see, and then suddenly they come BTHD. Oh my God, we are shocked. BTHD is negative. So people, how much of the counsel people come back to us. So actually, the first counseling has to be a little more generalized, a little more telling them, okay, this is what happened. Let's see what happens. So as a policy, we always make it a point to call the patient after a few days, like what, say, okay, let's get your menses, and then you come back. Then we will sit and discuss. Probably at that point of time, we talk to them more statistics, we talk to them more literature, we talk to them more this thing, because the first
Yeah,
time
yeah,
is
of course.
it's that completely flabbergasted. Anything that you're going to tell them is going to go from over their head. They're not able to ask. So I think first of all, the first time it's always tell them this has happened. I think it's I think an honest. One thing I've always realized: you honestly tell your patient something, they will listen, they will understand, rather than you try to uh, figure out or manipulate and tell them. They will get more irritated with that. But when you honestly go and tell them, any patients, that this is what happened, it is something that we could not do anything about, so we will have to see what is the problem. We'll need to further evaluate you. You come back, we will tell you what are your options, this or this thing, you go back. So
And
because
and then the counseling should be face to face,
huh
It has to be face to face where you then, because then they're asking questions and why this happened and what is the
and to be
prognosis.
very honest, I think I don't know how much of this counseling has to be done by a embryologist, because this
Right.
is like
I
it,
was about to
it-
come
this
to
is
this.
this is slightly, I think, beyond the scope of the basic counseling, because unless you're
This
totally
is no, but failure counseling in now majority laboratories around the world, uh, both the clinician and the embryologist sit together for failure counseling, especially for events which are related to the laboratory, like failure of fertilization, because sometimes clinicians may find it very difficult to explain a fertilization failure or explain a no blastocyst formation. So things are changing, and these are only issues which are related to the laboratory. So it's and you also have a reinforcement where two people are speaking the same language and are reinforcing the same information. So probably can be more effective, for the patient.
Absolutely, absolutely. These are the very important perspective to share any bad news. And with this is a clinical and embryological perspective. With this, we have Dr. Poonam Nair, ma'am, with us. Ma'am, would you like to add anything to this? Okay, probably she is busy.
It's, yeah, I would definitely like to add here that, in fact, there is a guideline for breaking bad news. Exactly what Sir said, that when there is bad news, then if there is a team, at least two, three people sitting together to explain along with the counselor, and that helps them to register much better, and the team can kind of complement each other in navigating the whole situation. There are guidelines given by the UK on how to break bad news. I think it would be very important if the embryologists can cover that. And I honestly think that uh, giving less information or more information, it's like some patients are hungry for information, like they are Google savvy, and they have 1,000 questions for which nobody has the answers. And then they are very simple, straightforward. They just want the basic outline. So, depending on the type of patient, I think we need to be geared to addressing their problems and their needs. Otherwise, the blame can just randomly fly off, and they leave the clinic giving bad name to the clinic also, to the entire. It's a bad experience for the entire team. So this grief which is there in the patient, it's a very complex emotional reaction. It's a mixture of anger, depression, non-acceptance, disbelief, going through various stages to process the grief. Normally, it takes actually 6 months. But here we have a patient who's got repeated cycles. So we have what is called unprocessed grief coming from very quick cycles in succession. And when I have had similar cases,
Is there
I
any
have
way to
taken them.
address this unexplained grief or repeated grief experience? How
This
to?
is what is called unresolved grief.
Mhm.
Grief is it's a process, emotional processing of a loss. And here the pregnancy never happened, but because the implantation was there, so for them, they were already pregnant. Somewhere in their mind, the baby was already sitting there, and they lost the baby. So it is like a bereavement reaction. And people cannot understand it because the baby they never saw. If a couple loses a child, everybody feels it. They're much more empathetic, much more emotionally engaged. But this is a child which never happened. That's why it's called invisible grief. For the outsider, it's invisible, but for the person, that it is like a loss of a real child. And normally it takes a lot of time to process it. If it is not processed fully, and before that you start introducing the next cycle, the next procedure, so this
But they don't have
cumulative
that
grief.
much time. Their AMH is declining. They are in hurry to have a child,
Yeah,
and so we are working
yes.
on very um,
Yes,
risky.
yeah, absolutely. I
Manish,
100% see the biological time, but here this is where we have taken the patient out for a limited period, like 3 to 4 weeks, and put them through deep relaxation, through counseling, through imagery, visualization, body scan, so that they are emotionally relaxed. And ma'am, I have seen patients with low AMH where the clinician said egg quality not good, please go for a donor. They refused. She refused. She says no. And with that one solitary egg, when she was in a deeply relaxed state, she got a successful pregnancy. So there are a
Wonderful.
lot of things where preparing the woman herself for the entire physiological complex, the reproductive system, through the mental processes, it can play a very vital role in my experience.
Thank you. Thank you so much, ma'am, for
Yeah.
your inputs. Definitely, we all trust that these emotional preparations are,
Manisha,
yeah.
yeah, see, I think now these negative results. See, I think a major reason why a lot of patients actually, after the first IVF failure with good embryos, good everything fails, and they just get so depressed and they go away and they come back after several years. At that point of time, the egg has gone down, the quality has gone down.
Absolutely. That's what I wanted to
That much
say.
of time is lost is purely
Lost.
because we are not, the communication is somewhere incomplete. We
Correct.
never been able to, while they started, because probably for some reason we are also at fault that the patient actually went without, and they got so depressed and they went away.
Yeah. Very true. So, since time is running short, so what we can conclude from these two questions, pre-counseling is must, and in difficult scenario, make the patient aware presumptively what all can happen, what all can go wrong, what your data says. And second thing, always keep in mind, when you are in a difficult situation, lab and clinic should sit together, discuss. And along with that, one more thing I feel is very important before communicating anything to patient. Communication between clinician and embryologist should be very, very clear, very, very precise. If they are not counseling together, the messages which are being given to the patient should be very, very similar, because they can perceive it differently, and there can be another issues which we might have to face. Again, the similar kind of difficult situation, if you can give your tips very quickly. The developmental arrest, we all see that embryos are looking great on day 3. We have 4 good day 3 embryos, but on day 5 there is nothing to transfer. So all got arrested before becoming blastocysts. So in such scenario, because on day 3 you have promised, okay, your embryos are looking perfect, they are good, that there is a case, 35 years old woman, first IVF, 4 fertilized embryo, all good grade, good grade on day 3, 8 cell grade 1, 2 7 cell grade 1, one is 6 cell grade 1, and they have consented to go for blastocyst transfer, and on day 5 all 4 arrested, zero blastocyst form. So how to share this information to the patient?
I'll
What?
tell you.
Yeah.
I'll tell you. Today there was a patient as I was leaving. She called. Today was day 3 for her, and she's a 41-year-old patient where only 3 eggs were retrieved.
Yeah.
And this is so in our center, after the embryologist counseling on the day of egg pickup, then they leave, and then they are given the option to call on day 3 for their first update. Sometimes we feel that, directly calling after 5 or 6 days is a bit too much for
Yeah.
some patients. So they like to be queued in. And so they want to call on day 3 and find out what's happening, with their embryos and how the eggs fertilize, and to give them a rough picture of, because in our center, mostly all patients go through blastocyst transfer. But whereas this patient has already had few cycles before, and she now knows that she's 41 years of age and she needs a PGTA, and so she is very expectantly waiting to see if she forms a blastocyst. But it has been explained to her amply that there is a lot of risk. We don't know whether we'll end up with any blastocysts or not, because we are starting with only 3 eggs, and we are dealing with very advanced stage. So today on day 3, she had 2 embryos. So all 3 fertilized. So I told her that, so all 3 eggs fertilized with conventional IVF. And today 2 embryos on day 3 are of good grade. They're looking good. And one of them is very slow growing. It has almost arrested. So she said, "What do you mean good grade? They are grade A or not? Are they grade A?" I said, "Yeah, they are. They look reasonably good, the way a 8 cell embryo should look on day 3. And what about the third one?" I said, "That's not growing well, and it's going to arrest." "Oh, okay, okay. So that's great news. It means that I have 2 good embryos today."
That is
So
the
I said, yes, but the main challenge starts now, is when a day 3 embryo has to convert into a good quality blastocyst. She said, "Okay, okay, okay." So I said, right now, this is the main challenge, and so we cannot be sure how these 2 embryos will progress to blastocyst. And she said, but you are saying that they are good right now, nah? That at least that you are saying
always
that they
wanted
are
to hear the good news,
correct,
what they
that they
want to
are
hear.
that they are very good right now.
Yeah.
I said, yes, they look reasonably good right now, but you know what? We really don't care about their grade right now, because what we care, because for us, what is paramount is for these embryos to progress to blastocyst, and only then we will be able to take it further, you know. So then she got the hang of it, that okay, because she was again and again trying to uh, focus on the fact that I have 2 good embryos, and that maybe, made her less anxious and made her feel good. Whereas I said that yes, it is, but let's hold on to our horses. Let's just be a little more patient for 2 more days, because now if I reinforce the fact that okay, yes, you have great embryos today, and then after 2 days you don't have a blastocyst, then all hell's going to break loose, right? So again, what I did was I was constantly managing her expectations. I did not want her to fly off the handle, going back and announcing to her family that, oh my God, I have got 2 great embryos today and things look fantastic. You know,
So
and
very balanced perspective is the key of communication,
yeah, yeah,
isn't it? Mm.
yeah.
So, and
So again, so all depends on pre-counseling.
right.
If I have not done this pre-counseling, then managing a no blastocyst report after 5 or 6 days becomes extremely hard.
Very true. Very true. And with this, since actually this discussion is very interesting and there are a lot many questions, I would like to take one question from the audience. Arijit Sen is there and he wanted to ask, nowadays one more major challenge we face is free AI platforms. Some gives statements even. The AI says, my embryo is excellent. Why didn't I get pregnant? Why I couldn't get a blastocyst? My embryos were good. The pictures you have shown, AI is actually giving outcome predictive results. So how to manage such scenarios?
Pursue.
See, I don't know about AI, or I don't know about. I've not. Fortunately, I've not got a patient. I've not started screening embryos with AI till now, so I personally don't have an experience. But yes, when we have a good quality embryos, we have a good endometrium, and sometimes patients.
We don't have implantation.
Yeah, we don't have, when you don't have an implantation, that is a key place we always talk to. So like I said, we go back to where we started off when we say that, when we say in the best of scenarios the your success rate is around 40-50%. That means there is always a 50-60% that you fail. And when you say it's a good, whenever this is exactly what I tell my patients. Whenever I say it's a good quality embryos, I'm visually saying, okay, obviously not the ones with PGTA and all those things, but I'm visually saying that. So whenever I see a person, if person is looking good, I cannot tell by looking at his face that he's got a heart problem or kidney problem. So there is a possibility that these embryos might look good but have some abnormality and it does not implant. So does not mean that all her embryos are like that. So I always put that perspective, and always, if it is the first failure, I'll be a little more reassuring. I'll tell them it's okay, this is the first time that is happening. I don't see that as going to be a big issue, and that next time you have to do everything in the market to enhance your implantation next cycle. I would still go ahead with the next cycle. If everything is looking good and everything is looking all right, I would still go ahead with the simple plain case, rather than trying to do everything that's available. But when it is more than two failures and things like that, is where probably I might think of, yeah, let's. So I think it is also to lot to do with, sometimes patients don't agree, but I think it, unless patients keep on insisting, what can you do more, what can you do extra, what can you add, when they keep asking me so many things, obviously I'd say, okay, these are the options. I honestly don't think this is necessary for you, but if you want to make sure that this is done, yeah, I say, I'll always tell, this is not still not proven, but still, if you want to do it, we'll try it and see. As long as it's not harmful, we can always try it and see.
Definitely. We day in, day out, we got to see such difficult scenarios because nobody can predict implantation rate, outcome of the report, because morphology can't be true predictor of their genetic makeup. And in spite of knowing the genetic makeup, we can't be very sure about their implantation potential. So these discussions are really very tricky. I wish to continue this discussion, but time is very, very limited. And I think we have to keep one more webinar on this sensitive topic. Always, with this, I would like to invite Bindu ma'am to give her perspective, the key conclusions with this discussion. But I would like to say here, precision in ART treatment, being an embryologist, always remember precision creates possibility, precision creates results, but empathy protects the hope, trust, and courage to continue the journey, which can give you results. So always listen patiently, share minimum, and whatever, be honest. with the communication. And in difficult scenario, always remember that the communication within a team is, before saying anything to patient, communication within team is very, very important thing. So after communicating with your clinician, you can talk to patient, but know your boundaries, be reasonable, be there, and rest. I would like Bindu ma'am to share on these discussions. Ma'am?
Well, thank you so much. Good evening, everyone. And it's wonderful to have such a good webinar on this topic. And it's good to have two different organizations associating, the IFS SIG group and ACE. It is like bridging the gaps. And today, whatever we have discussed is all about bridging the gaps. So congratulations to ACE and IFS SIG group for bringing up this very relevant and very important topic today. And I have been asked to put an ocean in a nutshell. After such wonderful lectures by Dr. Arvinder, Dr. Rajvi, with such wonderful inputs from Dr. Poonam, and an excellent panel, open discussion with Dr. Manisha, Dr. Gaurav, and Dr. Parsuram, what is left for me to really say? But then, just to conclude, customary, a formal thing, I would just like to say, technically, one correction, it's not just the human side. We are talking about the humane side of ART. It's like being humane is being human. So that is what we are striving at. And we have initiated this wonderful conversation. And to just sum it up, when we talk of counseling in ART, we are necessarily talking of the 4 pillars that ART stands on. We are talking about medical counseling, ethical counseling, legal counseling, and emotional counseling. So we are appealing to the intelligence quotient as well as the emotional quotient of the patient. We are addressing those 2 basic features that makes us all human. And therefore, when we talk of counseling, as Dr. Rajvi rightly said, it is not just counseling, it is communication, effective communication. And we are talking about the journey, walking the journey with the patient from despair to hope to trust. And counseling or effective communication is nothing but building of this trust. The fact that the patient has come to us for treatment, that means there is some ray of hope in their hearts. They have come for a result. That is the hope. And the medical counseling that is there, explaining all the academic things and the medical jargons, that may satisfy their intelligence quotient, but it is the emotional aspect that we deal with, which is going to help build the trust. And what else is going to build the trust? When we talk to them in a very convincing manner, confident manner, in a transparent manner, we make them and sit down that these are the facts. That is what builds the trust. And that helps them, not just gives them false hope. We talked of false hopes earlier. We are not trying to give them false hopes by saying that everything is good, don't worry, we'll take care. No, when we are transparent, when we have effective communication, we are building the trust that the patient feels whatever is done with me is the best that can be done for me. So there is no scope for ambiguity in the patient's mind that, oh, did the doctor lie to me, or was there some ambiguity in what the patient told me, or was it the half truth? No, you have to sit down with the patient right from the beginning. And there are different levels, of course. When we said that we are communicating with the patient, there is a different level. So it's not a conventional psychological counseling. The clinician has one level of counseling. Then you have a counselor. Now that we have counselors also in ART clinic who will deal more with the emotional aspect. And today we have brought up a very relevant topic about how much is the embryologist involving in counseling. So medical counseling, psychological counseling, or emotional counseling to give them, to rekindle that hope, to keep alive that hope, and then the embryology counseling. And at all these levels, the communication, as Manisha, you rightly said, the communication between the clinician and embryologist, the clinician and the support staff is also necessary. So that whenever the patient asks a question, there is uniformity in the kind of answer that comes up. If an embryologist says to the patient that your embryos are quality grade A. Don't leave any scope for imagination there and say that they are reasonably good. That means you are not sounding convincing. You are somewhere not trying to give them that hope. If they are grade C, they are grade C. If they are grade A, they are grade A. But grade A does not always extrapolate to implantation. Grade A, day 3 embryos do not extrapolate to blastocyst. So we have to see at different levels. So when you talk of embryology counseling, before ovum pickup also, because the embryologist has seen the semen quality as well. So right from what the semen quality was, the embryologist has to know also the clinical background about what the stimulation protocol was, at least the reason for or indication for IVF. So, I mean, a clinician has to know little of embryology, and embryologist has to know the clinical background to be able to communicate with the patient. I mean, when the patient asks a question, you cannot just be speechless standing there that I'm not aware. So, or if there are more details, the clinician can provide you the details. So there has to be a good communication between the entire setup. It is a holistic approach that we are talking about when we talk of patient counseling or communication within an ART setup. It's at a multi level. So as was rightly discussed, how much should the embryologist talk? Just to give an example, how in one simple example, we can give the patient counseling at different levels. For example, the male is azoospermic. He is aware of it. His parents are aware of it. And one fine day, the father of this guy comes up and tells the clinician or maybe the embryologist or andrologist that we know what the situation is. If we have been advised donor sperm, can we use my sperm to use as donor? Now, these are circumstances where we have actually seen such things happening, where the father of this male comes up and says, can we donate? So now telling the patient is not just about telling that, no, you cannot donate because the donor has to be anonymous. The donor has to come through the bank. Then the patient also, this father also says that, okay, what if we route the sample through the bank? Can you not use it? Then arises the question about the age. And then finally, also, not just these things, the ethical and emotional aspects of doing such a thing. So in a very convincing manner at different levels, this one example itself encompasses medical, legal, ethical, and emotional. Because for them, it is as simple as hamara ghar ka chirag or hamara DNA hamara hi rahega. But then to explain to them at different levels is very important. And this is where communication plays an important role. So I think that in a nutshell is what communication and counseling is all about. And one very important point that Dr. Arvinder pointed out, that in doing all this, now if we have this added communication with the patient also, it is for us when we are doing this kind of a counseling, it adds to our passion, it adds to our exhaustion. So self-care, I mean, also is important. To draw a line of how much and what not to do is also important for the IVF specialists, be it the clinicians, embryologists, or the other staff. So in doing all these things, not to get overexhausted, to have sufficient staff to be able to do all these things is also very important. So I think that was one very important point that Dr. Arvinder highlighted. And I think that is all that I hope I have been able to cover most of the points that I could in conclusion. If anything is left out, maybe Dr. Rajvi can add.
May I add something here, ma'am?
Yes, please. Yes, please.
This a course has been launched between in association with Amity University Molecular Medicine Department and IFS. It's a 1-year course on infertility counseling, and it is to train people with either psychology background, postgraduates in psychology, or it can be nurses or anybody who's already working in the IVF centers, because counseling, it has shades, all shades, from information sharing to subconscious healing. There's many processes, in-depth processes involved. So this has been launched this year only. And we hope that we will have professionally trained counselors who can bridge the gap between the patient and the hardcore medical team. Okay, thank
Absolutely,
you.
ma'am. We'll be needing, nobody can replace our professional counselors. But today we were discussing, our discussion was focused only how much embryologists should communicate. These courses are going to be very,
Yeah.
very beneficial to shape up the infertility practice in our country. And with this, we would like to sum it up, although it is an ongoing discussion. And as Bindu ma'am has beautifully summarized, and with this, I would like to invite you all to our upcoming conference, ACE, which is going to happen in Agra in August. You all are very much invited, and there we would like to have such sessions and open discussion with everyone how to shape up things better with the counseling perspective as well. With this, I would like to convey a heartfelt thanks for all of you for being here, for sparing your valuable time, and for giving such a valuable input. With this, very good night and
Thank you.
enjoy your evening. Thank you so much.
Thank you so much. Thank you so much, everyone, for making me a part of this. Thank you.